Uh, Good afternoon, everyone. Today we'll be talking about a common topic, common cold. This is my first video for my YouTube channel based on Nielsen-based teaching, and I'd like to start from a most common topic, common cold, which is actually mistreated in office practice. We'll go through the basic understandings and the clinical aspects of it. First, the definition of common cold. The common cold is also otherwise called as infectious rhinitis, rhinosinusitis. It is actually an acute viral infection of the upper respiratory tract. Here I want to make clear that the definition of upper respiratory tract is something above the glottis. The definition of upper respiratory tract is something about the glottis, and usually the common cold is caused by it is defined as a viral illness. The most common viruses among the virus causing common cold is rhinovirus, coronavirus, respiratory syncytial virus, and human metapneumoviruses. Some uncommon viruses are influenza virus, parainfluenza virus, adenovirus, Coxsackie, and enteroviruses. You have to know the basic association of these viruses causing other disease. The rhinovirus, coronavirus, RSV, HM, human metapneumovirus all will cause bronchiolitis and wheezing. Human metapneumovirus is also associated with croup. Influenza and parainfluenza virus can cause croup, pneumonia, and flu-like illnesses. Adenovirus can cause pharyngoconjunctival fever, and Coxsackie virus and enterovirus can cause herpangina and aseptic meningitis. Coming to the seasonality of the common cold, it is an year-round occurrences. Usually we get common cold, we basically label them as upper respiratory tract infection all the year round, but there is certain some seasonality differences with maximum occurring in the northern hemisphere in the October to August-October window and the April-May window, which is either the late spring or the early fall. And the winter times, it is usually caused by the respiratory syncytial virus, influenza virus, metapneumovirus, and coronavirus. Coming to the frequency, this will be an obvious question which is arised by the parents. Like, my child is getting frequent colds. It is normal on an average study conducted. Children are observed to have about 8 colds per year, and 10% of the children can even have up to 12 colds episodes per year. And as the age increases, the incidence decreases. Coming to daycare, which is not very popular in our country, India, but in US, in children when they are left in daycare in early infancy, they have increased frequency of cold. But the children who are kept in home and then sent to school, they tend to have more cold in the kindergarten period, whereas the daycare children tend to have less cold. This may be due to the early environmental exposure to RSV viruses in the daycare settings. The transmission is by 3 methods. The viruses get transmitted from one person to another person, either by direct self-inoculation. In this, like the patient touches a contaminated object or the other person's nose, and then he himself keeps his hand over his nose or the eyes. And there is small aerosol inhalation and large aerosol deposition. In reading medicine, particularly medicine, there has to be basic level of English understanding. Small aerosol is given as inhalation because these small aerosols, by definition, are particles with size less than 5 microns. And influenza virus and coronavirus are majorly spread by small aerosol inhalation. The large aerosol deposition is by sneezing, and the droplets gets deposited into another person's eye. This large aerosol is usually 100 microns in size. And by self-inoculation, human respiratory rhinovirus and respiratory syncytial virus are preferentially spread by self-inoculation method. Okay. Man versus bug, the bug always wins. This is a famous proverb which is done to elucidate the superiority of the bug against us. So, how does the virus escape our immune system. There are certain evasive techniques only which the viruses deploy, so they escape our immune system, and even as adults we tend to have cold often and often. Why does our body does not develop a permanent immunity against common cold? The first evasive technique is the body after one episode of cold produces immunity against one particular serotype of the virus, but there are large number of serotypes of the virus. This is one mechanism. Another mechanism is a antigenic drift. The antigenic drift is a simple thing where the influenza virus changes the pattern of the antigen it presents on the cell over a period of time. This causes the influenza virus influenza virus would not be detected by the body over a period of time, and we tend to have this flu-like illnesses over a period. And this is a point which is kept in mind by the World Health Organization while designing the influenza virus over a period of time, that is in every year they design serotype specific and type specific viruses separate for the both northern and southern hemisphere, and it is circulated throughout the world so that each hemisphere gets the protection against the virus which is in circulation at that time. And the third type is a short-lived IgA immunity. Viruses which affect us the upper respiratory tract is usually protected by the immunoglobulin A. This is immunoglobulin A is a secretory immunoglobulin, and it is also fondly called as mucosal paint. It paints the mucosal surfaces, but this IgA is short-lived and very short incubation period. The body does not have time to react and produce mountain immunity against the viruses because the viruses just have an incubation period of ranging somewhere about 3 to 5 days. Pathogenesis of the viruses. The viral infection, nasal epithelium, the pathogenesis of the virus, we can understand this. Virus gets introduced into the into our upper respiratory tract. The nasal epithelium destruction is either happening or there will be no apparent histological damage in our upper respiratory tract. Acute inflammation and release of inflammatory mediators do happen, and this in turn causes vasodilatation with the release of inflammatory mediators, and the polymorphonuclear cells gets attracted to the point. This in turn causes vasodilatation in the local upper respiratory tract epithelium, and then the symptoms develop. The symptoms can either lead on to complications, the symptoms can spontaneously resolve, or there can be a prolonged course of illness after which the viral shedding will happen and then the symptoms get resolved finally. Coming to the common clinical symptoms of these viruses or the viral upper respiratory tract illness, which is common cold. Children's, usually infants, the definition of an infant in pediatrics is in age less than 1 year. Presents with fever and nasal discharge. Older children presents with scratchy throat, nose block, running nose, cough, mostly due to postnasal drip, malaise, headache, decreased appetite and sleep disturbances. To understand postnasal drip is something like a running nose which happening in the posterior part of the nose, where the watery secretions or the nasal secretions drip into the larynx and it causes irritation and then the baby coughs. So this is postnasal drip. So this comes to the symptoms. The signs of what we elicit an upper respiratory tract infection is there will be an obvious nasal discharge. It may be watery or it can change in color. The caveat in the nasal discharges, patients will come and tell, sir, my baby is having green color mucus, or in Tamil, which we say, en paapakku pacha color la sali irukku. This does not indicate a bacterial infection. This on face value does not indicate a bacterial infection, and this alone should not be taken by our doctors as an indication to stock antibiotics. The change in color is due to the accumulation of the neutrophils which is in turn an pathogenetic response which we studied earlier, where PMNs are attracted, and this causes the change in color. It is not a superadded bacterial infection. And another finding which you can find is a swollen erythemata turbinase. There will be redness or redness in the pharynx, tonsils, anterior tonsillar bed, anterior tonsillar pillar. There will be conjunctival injection, and there will be anterior cervical lymphadenopathy. So these are the symptoms which come in, signs which we do expected the common cold. Diagnosis. The role of the clinician in diagnosing a common cold is not to diagnose common cold, which is very easy, but to rule out other common conditions like allergic rhinitis. In allergic rhinitis, apart from this, itching predominates. You get itching predominates. There will be scratching of notes. There may be an allergic salute, and a family history of atopy may also be present. And if we are too geeky person, which we don't do in a clinical practice, there is something called as a Hansel strain, where you take the nasal discharge and then stain it and you demonstrate eosinophils. We don't do it usually in the clinics because allergic rhinitis is diagnosed by clinical things. For vasomotor rhinitis, the features which may clinch the vasomotor rhinitis is association with certain symptoms like spicy food, and after eating spicy food, water discharge is normal, but persistent sneezing, nasal obstruction after some spicy foods, or nocturnal or diurnal variations where you get more symptoms in night and in the morning. In the rhinitis medicametosa, that is a rebound nasal discharge after you stop decongescence. After you stop what? Decongescence. It's like xylometazoline. These decongestants are topical. And foreign body. Foreign body, there is a rule in foreign body which says that unilateral bloody discharge, foul smelling in nose is foreign body unless proved otherwise. Sinusitis, one of the complication of a common cold is sinusitis, but and because the sinus is in continuation with the nasal epithelium and the pharyngeal epithelium, concomitant rhinosinusitis can be present, but acute bacterial sinusitis as such should be suspected only if this is a prolonged symptom of the above said fever, cough, cold, running nose for 10 to 14 days, or the patient develops facial swelling or facial pain in any time of illness. You have to understand any time of illness. This prolonged symptom of 10 to 14 days is a mild running continuous fever, those things. But if you develop the facial swelling on one side or facial pain tenderness, then you have to suspect acute bacterial sinusitis. Streptococcosis is due to Streptococcus infection of the nasal epithelium caused by persistent discharge, and you will get a classical excoriation in the external nerves. Pertussis, this is called as a whooping cough, which an experienced clinician will never miss. And congenital syphilis, with before that pertussis will present with a classical oof. Congenital syphilis presents as persistent running nose in first 3 months, and CSF rhinorrhea. This is usually uncommon, but I just wanted to say just nasal discharge which is very thin, nasal discharge, watery, more on bending down. The patient will give a history as not as மூக்கு சளி வருது or they have nasal discharge. It comes as I have water running down. Can be CSF rhinorrhea. So these are all the DDs which you have to consider before you make a diagnosis of common cold. Lab. There is no necessity to do any lab investigation in a common cold child. It's nothing considered like even a basic lab investigation. It's purely clinical, and purely if this is not severe, it won't be severe, and it is a case for an outpatient department, not an inpatient department. And the other cultures, polymerase chain reactions and antigen testings are done only for suspected pertussis or streptococcosis. The treatment for common cold, now we have diagnosed the common cold based on the symptoms and based on the presentation. Now coming to the treatment for common cold. First, antiviral treatment. For a simple common cold which comes to your clinic or your hospital, no antivirals are required. Sometimes antivirals are required for severe respiratory syncytial virus infection or a severe influenza virus infection, which the baby will not be in a outpatient treatment. You would have admitted the baby already. So some ribavirin is used for severe respiratory syncytial virus infection, and oseltamivir or zanamivir can be used for severe influenza virus. The main treatment of mainstay of treatment for common cold is supportive care. The supportive care is this. These are the advices which you ought to give the parents so that the baby feels better. You have to increase the hydration, ask the baby to drink lots of water, more water based foods, and nasal saline for irrigation and warm water ingestion, which in turn causes soothing sensation in the throat, and the baby or the child feels better. Regarding non-prescription therapy, the non-prescription therapy are therapies which are found commonly in clinics or the medical shops, where you go and say I have a common cold and they give you non-prescription drugs. These drugs usually contain a cocktail of cough suppressants and antihistaminics and organic extracts. These non-prescription therapy are not included in pediatric treatment, and they are not recommended below 6 years. And in more than 6 years, if you ask, will you give? I will not prescribe any non-prescription remedies, but the benefit of giving them and the risk of giving them should be decided by the clinician, and they are not recommended in general in clinical practice. If we can give zinc for a common cold, because zinc has a inherent antiviral property in certain studies and has the ability to regenerate the nasal epithelium as such, but it is not proven. In common cold, the baby may have fever. Fever is best managed by plain paracetamol. The paracetamol, the dosage is 10 to 15 mg per kg per dose. You can give once in 6 hours, or fever can be done by managed by NSAIDs like brufen and mefenic acid, but generally it is not required. We recommend only giving paracetamol. There is no role of aspirin in management of common cold or any fever in children because of the fear of it causing Ray's syndrome, particularly due to influenza virus infection. The nasal obstruction is due to the discharges getting dried up, and it can be used can be cured using saline nasal drops or saline irrigation in less than 6 years of child. In more than 6 years, there is topical decongestants. These topical decongestants are adrenergic agents, which in turn causes submucosal vasoconstriction, so that the vasodilation caused by the viral infection is diminished, and these agents causes submucosal vasoconstriction, and these agents act immediately. So the child gets an immediate relief out of the nasal obstruction. and reduced strength formulations, 0.025% of xylometazoline are used in children rather than the 0.05% which is used in adults. And we have already explained about the condition called as rhinitis medicamentosa, which is caused by long term continuous usage of xylometazoline and the rebound nasal congestion, nasal obstruction caused when withdrawing the drug. So that in clinical practice, it is not advised to give xylometazoline for more than 3 days or 5 days continuously. And we don't ask people to store xylometazoline and use it in the next time, because people tend to do those things with all the medications which we give. So educate the patient about rhinitis medicamentosa and better avoid prescribing xylometazoline. If you are going to prescribe, do it in only more than 6 years old child and tell them you have to use it for a short duration. Rhinorrhea. Rhinorrhea is just running nose or nasal discharge. We don't treat rhinorrhea. See, there is a virus which is foreign to the nose, and the nose, the body reacts so that it increases the vasodilation and creates a flow like falls or waterfalls, so that the virus is wiped away from the body. So this is rhinorrhea is a protective mechanism in common cold. We do not treat rhinorrhea if it is not too disturbing for the child. Non-disturbing mild rhinorrhea, leave it as it is. Or if the child is too bothering or the rhinorrhea is too bothersome for the child, it can be treated by using first generation antihistaminics. The first generation antihistaminics and second generation antihistaminics are two different types of antihistaminics. The first generation antihistaminics usually has this anticholinergic property. It does not help by its antihistaminic property, it acts by its anticholinergic property, so that it dries up the, it decreases the secretion in the nasal cavity. For example of first generation antihistaminics are promethazine, which trade name is Phenergan, and phenermin. The side effect of this first generation antihistaminics is the sedating effect. The second generation antihistaminics are generally cetirizine, fexofenadine. Those types of drugs are non-sedating, but as such for treating rhinorrhea, it is not as effective as the first generation antihistaminic, but you do find clinicians using second generation antihistaminics for treating common cold. Sore throat, just hot water drinking and paracetamol will help in the sore throat. Cough. Cough is a self-limiting episode in a pure upper respiratory tract infection. Cough usually is treated by either giving a cough suppressant or a bronchodilator and a mucolytic. Both are not required in a plain upper respiratory tract infection. The first generation antihistaminic which you had given for rhinorrhea itself will take care of the cough. In smaller children, you can use honey mixed with hot water, which gives a modest relief in the symptoms of cough, and it suppresses cough by a natural remedy. But honey is not given in children less than 1 year because of fear of botulism. Don't give honey in children less than 1 year. A bronchodilator, mucolytic. The only indication of using a bronchodilator in upper respiratory tract infection is that this can trigger a viral associated wheezing, that is viral associated hyperreactive airway disease. So this is the only indication for giving a bronchodilator in an upper respiratory tract infection. And last but not least, these treatments don't have any effect in URI, so it is better not to give them. For example, vitamin C, zinc, vitamin D, steam inhalation, and echinacea, which is a herbal compound. So these are the treatments which you have to give for an upper respiratory tract infection. So upper respiratory tract, the simple, uncomplicated upper respiratory tract infection is like the famous Rajini's dialogue. If you give medicine, it will get cured by 7 days. If you don't give medicine, it will get cured by a week. So this is what you get in a simple upper respiratory tract infection. So in this upper respiratory tract infection, the main take home message, if you have not at all listened to anything of my talk, leave it. But a big no to antibiotics. Irrational usage of antibiotics in a common cold is next to criminal negligence. Even though does not affect the particular child, it will cause antibiotic resistance in the general population, and our antibiotics are already losing their potency and efficacy because of resistance, and we will be one day left with no antibiotic to fight a superbug. So don't give antibiotics in a upper respiratory tract infection. So okay, now there will be a question regarding, sir, there is an upper respiratory tract infection, but I am not sure whether this is a streptococcal throat, strep throat or streptococcal pharyngitis, where antibiotic has to be given mandatorily. So what will I do? How can I decide? Because it comes as an OP case, we cannot ask for any investigation, and the investigations are quite costly. In that case, you can use a simple bedside scoring system that is called Centaur scoring or McIsaac scoring. In this scoring, there are 5 parameters. First, I will read out the parameters. The first parameter is, first, if the child is aged between 3 to 14 years, you can give 1 point. And you have a child with fever more than 100.4 degree Fahrenheit, then give 1 point. If you have acute anterior cervical lymphadenopathy, neck nodes are common in a growing child, but if the neck node is enlarged, which is more than significant size of more than 1 centimeter, and if it is painful, then it is acute anterior cervical lymphadenopathy. Absence of cough, clearly underline, it is not the presence of cough which gets a point, it is the absence of cough which gets a point. If the cough is present, you give 0 here, and you see a tonsillar swelling or an exudate, then you give 1 point. So you take all these 5, score it. If your child scores 4 or 5 out of 5, then that is a definitive need for antibiotic. And if your child scores 1 or 2, then there is no definitive need for antibiotic, you just stick on to your supportive treatment. But if the score is 3, which is cat on the wall situation, it is the clinician who has to decide on whether to start an antibiotic or not. This, as to a large extent, will reduce the inadvertent administration of antibiotic for a common upper respiratory tract infection, which by practice you can do it in no time, in less than 20 seconds. Okay, coming to the complications of upper respiratory tract infection. Upper respiratory tract infection can cause acute otitis media. The pathogenesis is simple because upper respiratory tract gets infected, there is swelling and edema, there will be blockage of the eustachian tube, and the middle ear gets swelled up, and you have a child who had a URI 2-3 days back, comes to you with complaints of ear pain and discharge in the ear. This is acute otitis media. And second is sinusitis. Sinusitis, because it is in continuation with the nasal epithelium, the sinusitis is very common in children who is having URI. But you don't give, it is also self-resolving, but you don't give antibiotics in sinusitis. Bacterial sinusitis should be suspected, as said earlier, when there is prolonged symptomatology for more than 10 to 14 days, facial swelling or facial pain, which is of recent onset, or which whenever it gets in onset, you have to consider antibiotic. Then the upper respiratory tract infection can cause a complication which can cause wheezing in a small child. This is the viral associated hyperreactive airway disease. And finally, the inappropriate use of antibiotics, which is not a complication of the disease per se, it is the complication of the doctor treating a common cold, will cause antibiotic resistance. Prevention. Simple measures like hand washing or usage of sanitizers, which the doctor herself should first handle it. Before you see a next patient, make sure you practice hand washing particularly, or if it is not feasible, at least make sure you use the alcohol based hand rubs in a correct way, not just put it, rub it. At least the minimum contact time required for an alcohol based hand rub is 20 seconds. There is no definitive chemoprophylaxis which is advocated for a simple URI. Vaccines like influenza viruses vaccine can be used in children to prevent severe influenza, which is usually a complicating lower respiratory tract infection, not an upper respiratory tract infection. Okay, that's it for the URI session. Hope you like this, and I have made certain points clear in clinical practice, and if this get observed by the fellow medical practitioners and antibiotics are not inadvertently prescribed, I will be happy for the same. Thank you.